Alright, so let's talk about the new 2026 Acute Pulmonary Embolism Guidelines in adults, which came out this year in February. I've tried to cover all the important recommendations as mentioned in this guideline in the next 7 to 8 slides. So if a patient comes with acute onset dyspnea, chest pain and hemoptysis, a pulmonary embolism is high on my differential, right? And if the history and physical exam point towards the same, what do we do next? Before going for the definitive imaging or the definitive testing, we do some scores to check for the pre-test probability. Pre-test. So before a test, we are going to check how high is the probability that the patient does have a pulmonary embolism. So we can use the Wells score, the revised Geneva score, and so on. So as per these scores, my patient could have a low, intermediate, or a high probability for a pulmonary embolism. What next? If my patient has a low probability, we do a PERC. What is a PERC? PERC stands for Pulmonary Embolism Rule Out Criteria. Now, if this criteria is met, then I can rule out pulmonary embolism. But if this is not met, then we go to the years algorithm. Now, let me tell you, PERC is a set of 7 questions. If the answer to all the questions is no, then we have ruled out pulmonary embolism. If, however, answer to even one question is yes, then we know that this patient could have a pulmonary embolism. It has not yet been ruled out, and then we go to the years algorithm. Now, if my patient has an intermediate probability, we directly go to the years algorithm. Now, what is this algorithm? If my patient has 0 years items, now what are the years items? One of these, a clinical signs of DVT or hemoptysis, or if pulmonary embolism is the most likely diagnosis. If my patient has none of these, then we do a D-dimer, and here the cutoff is more than equal to 1000 nanograms per ml. So either this, or if my patient has more than 1 year's items, plus the D-dimer cutoff here is lower, it's more than 500 nanograms per ml, or there's an age adjusted D-dimer cutoff which is more than equal to age into 10 nanograms per ml. So more than equal to 1 years plus D-dimer more than 500 or more than age equal to 10, or like I said, 0 years plus D-dimer more than 1000. This means the years algorithm is positive. If it's negative, then again we have ruled out my pulmonary embolism. If it's positive, then we go for the definitive testing. Also, if the patient has a high probability in the pre-test probability scores, then we do not waste time on the years algorithm. We directly go for the definitive testing, which is the CTPA. CTPA is the investigation of choice, a CT pulmonary angiogram. And note this, that this guideline mentions that even in pregnancy, we can use a low dose CTPA. So earlier we used to be worried about the radiation exposure in pregnancy, but this guideline specifies that a low dose CTPA can be used in pregnant patients. Now, CTPA is better than a VQ scan, and if you're using a VQ scan, a SPECT is better than a planar, and a VQ scan is better than MR angiography, right? Now, if we are suspecting PE in a pregnant patient, first of all, we look for signs and symptoms of DVT, a deep vein thrombosis. And if these are present, then we do a compression ultrasound. Now, this does not have any radiation exposure, and this can even be done at bedside. And if this is positive, we directly go for the treatment. We do not need to waste time on D-dimer or say a CTP and so on, right? If, however, there are no signs and symptoms of DVT in a pregnant patient, or the compression ultrasound is negative, then obviously we have to go through the years algorithm and then manage the patient accordingly, right? Now, based on all of these, we have categorized the pulmonary embolism patients into these categories in the new guidelines: A, B, C, D, and E. And B has been subcategorized into B1 and B2, C into C1, C2, and C3, D into D1 and D2, and E into E1 and E2. And as you go from left to right, the severity increases as well as the adverse outcome risk also increases. So let's come to the categories one by one. So category A stands for asymptomatic. So these patients were undergoing some investigation for some other disease, and there could have been an incidental finding that the patient also has PE. So these patients are category A. What's category B? You can remember it B with the phrase bit of symptoms. So these patients have a low clinical severity score. And what scores are we talking about? We're talking about PESI, simplified PESI, Hestia score, and so on. So in short, B category patients have a low clinical severity. What's C? C stands for clinical severity, which is a clinical severity score is high. Also C stands for cardiac involvement. So from C category onwards, we are going to look for the cardiac involvement in our patients. What's D? D is incipient cardiopulmonary failure. You can remember it with the word developing. D for developing cardiopulmonary failure. What's E? E patients have a definitive cardiopulmonary failure. Or you can remember it with the word evident. E for evident cardiopulmonary failure. Right? So these are the broad categories of our pulmonary embolism patients. We no longer use the massive submassive criteria. We are going to use A, B, C, D, E. Let's come to the subcategories. B has been subcategorized into B1 and B2. B1 means there is one or more subsegmental involvement, and B2 is segmental involvement. You have heard about the bronchopulmonary segments. So B2 it has a segmental involvement, and B1 is subsegmental, more peripheral, right? What's C or the subcategories of C? Now I said C for cardiac involvement. We start checking for the cardiac involvement from C onwards. So in C1 patients, there is a normal right ventricular function as well as normal biomarkers. Now what biomarkers are we talking about here? We are talking about the cardiac biomarkers like the troponins, the NT-proBNP, and so on. C2 patients have either abnormal right ventricular function or more than one abnormal biomarker. And what C3? C3 is both an abnormal right ventricular function and more than one abnormal biomarker, right? Now what are the subcategories for D? D1 is transient hypotension and D2 is normotensive shock. Now what is transient hypotension? Hypertension means my patient would have a systolic blood pressure less than 90 millimeters of mercury, or there has been a decrease by more than 40 millimeters of mercury. And this is transient, meaning it lasts either less than 15 minutes or is responding to IV fluids, right? Now what's normotensive shock? Normotensive, so normal BP plus any one feature suggesting a shock at the tissue level, which could be a lactate more than 2, or a developing AKI, or the low urine output, or a new onset mental status change, or a low cardiac index, right? So these patients have normotensive shock. BP is normal, but at the tissue level there is shock. What are the subcategories of E? E1 is a recurrent or a persistent hypertension. Now remember I said in D1 there was a transient hypertension, but here in E1 the hypertension is either recurring, you're giving management but it's recurring again and again, or it's persistent despite your treatment. So presence of a recurrent or persistent hypertension plus a cardiogenic shock. And what's E2? It's a refractory cardiogenic shock. So nothing is working anymore, the patient is in cardiogenic shock, or the patient has developed a cardiac arrest. So you're giving CPR and all, right? So these are the categories and subcategories, right? In addition to these, there is something called a respiratory modifier. So suppose I have a patient who has a high clinical severity score and say only an abnormal right ventricular function. So this patient would be a C2 category. Now in addition to it, if the patient has the SpO2 less than 90% or the respiratory rate more than 30, or there is a need for supplemental oxygen, then we are going to classify the patient as C2 plus R, right? So for C, this was the respiratory modifier. What's the respiratory modifier for D? It's a requirement for oxygen support at the rate more than 6 liters per minute via nasal cannula, or the need for an NRBM. And what's the respiratory modifier for E? It's hypoxemic respiratory failure or a ventilatory failure, like your T1RF and T2RF, right? And how do we manage the respiratory symptoms or the hypoxia? We are going to prefer a heated high flow nasal cannula over a normal nasal cannula, and we are going to avoid an unnecessary mechanical ventilation and deep sedation. Now, obviously, if the patient does have a hemodynamic collapse or needs a mechanical ventilation really, then obviously we are not going to prevent that. However, we are not going to provide mechanical ventilation unnecessarily, right? So let's come to the rest of the immediate management for our acute pulmonary embolism patients. Now, for categories A, B1 and B2, we are going to send them home. We are not going to hospitalize them, and we are going to manage them on an OPD basis, right? From C1 onwards, we have to hospitalize our patients, and we are going to involve PERT. What's PERT? PERT stands for Pulmonary Embolism Response Team, and this team could involve people from different specialties like cardiology, pulmonology, cardiothoracic surgery, nursing staff, and so on. Now, what about right ventricular imaging without evidence of shock? We are going to do this by echo, and we are going to prefer this echo over a CT scan. Now, remember I said from C onwards, we check for the cardiac involvement, right? So, C category patients were patients with high clinical severity and with or without a right ventricular dysfunction and plus minus biomarker increase, right? And D1 was what? D1 was transient hypotension, and D2 was a normotensive shock. So, none of these patients actually have a frank low BP or a frank picture of shock clinically, right? Only D2 might have the features that I mentioned, that like the increasing lactate, decreasing urine output, and so on. Otherwise, none of them actually have a real picture of a shock patient that we are used to seeing, right? So, despite that, we are going to screen for right ventricular dysfunction in these patients with the help of echo. Now, in E1 and E2, these patients already have a frank cardiopulmonary shock. So, once the patient already has a disease, there is no point of screening, right? That's why we have not mentioned about imaging in these separately, right? Now, coming to anticoagulation, this is the main therapy for pulmonary embolism, and we are going to provide it to all kinds of patients. To patients of categories A, B1 and B2, that is the patients we are sending home, we are going to prefer DOACs, the directly acting oral anticoagulants, and these are preferred over vitamin K antagonists. Now, there are exceptions. In pregnancy, LMWH or UFH are preferred. In antiphospholipid syndrome, VK is preferred, and in liver failure child park C, DOACs are contraindicated. So, except for these, in almost all kinds of patients, DOACs can be given from A to B2 as a management of anticoagulation. Coming to C1 to E1, in these patients, we are going to give parenteral anticoagulation in the form of low molecular weight heparin. And in E2 patients, we can either give low molecular weight heparin or unfractionated heparin as per the patient's requirements, right? Now, suppose there is a high risk or a high chance of pulmonary embolism, and the clinical category would be higher than C2. In these patients, if there is a delay in imaging, we are going to give an empirical anticoagulation. Even if we don't have a proof right away on imaging that the patient definitely has a pulmonary embolism, we are going to give the dose before we send the patient for imaging. Now, coming to systemic thrombolysis, in E1 and E2 patients, systemic thrombolysis in addition to anticoagulation is reasonable, and in D1 to D2, systemic thrombolysis may be considered in addition to anticoagulation. Now, what about catheter directed thrombolysis or mechanical thrombectomy or a surgical embolectomy? The E2 patients are already very severe, right? They are having cardiac arrest and so on. So, these patients cannot be shifted to a cath lab or an OT, right? So, we are not going to try these therapies in an E2 patient. However, these are reasonable in E1 patients in addition to anticoagulation, and in D1 and D2 these may be considered on a case to case basis in addition to anticoagulation. Now, which is better, a systemic thrombolysis or these? Now, the guideline says that there is no evidence that these are better than systemic thrombolysis. However, to reduce the bleeding risk, we might prefer a catheter directed thrombolysis or a mechanical thrombectomy, and if there is a high risk of intracranial hemorrhage, we might prefer a surgical embolectomy, right? However, all these are in addition to anticoagulation. Now, coming to vasopressors plus minus inotropes, we are going to give them from D2 to E2. Remember, D2 was normotensive shock and E1 and E2 were frank cardiopulmonary shock. And we are going to start with noradrenaline, and if the dose exceeds more than 15 micrograms per minute, we are going to add vasopressin, right? Now, what about IV fluid boluses? Now, our pulmonary embolism patient has a right ventricular dysfunction, right? So, we are going to give IV fluid bolus very cautiously, only about 500 ml in D1 and D2, right? And we are not going to give more than that, and we are going to monitor the patient very closely for any cardiac failure. And also note this, for C3 patients, we are going to monitor the MAP or the mean arterial pressure very closely, and if it drops below 80 millimeters of mercury, we are going to escalate management, right? Coming to inhaled pulmonary vasodilators, these may be considered from C2 onwards because these reduce the right ventricular afterload. What about IVC filters? We are only going to use retrievable IVC filters, and we might use them in very specific cases from B1 onwards. That is, if the patient has a recurrent pulmonary embolism despite anticoagulant therapy, or if there is any absolute contraindication to anticoagulation. Only in these selected cases, we might use retrievable IVC filters from B1 onwards. Now, category C to E patients who are requiring sedation for intubation, for these patients, we are also going to keep vasopressors, inotropes, and the VA ECMO. VA ECMO is veno-arterial ECMO ready, so that these might be available anytime the patient becomes unstable. And in E2 patients, that is a patient with cardiac arrest and so on, we are the guideline specifies using a VA ECMO for better management, right? Now, I've covered the management of hypoxia in the last slide and the management of the pulmonary embolus per se in this slide, as well as the vasopressor therapy, that is the hemodynamic support. But remember, I mentioned that the patient can present with dyspnea, which I already covered, hemoptysis and chest pain. Now, this guideline does not mention the management of chest pain and hemoptysis in a pulmonary embolism patient. So, I'm not going to discuss this here. However, if your patient does come with these, you have to manage these accordingly. So, next we are coming to post-acute care. So, I have discussed the immediate or the acute care of our acute pulmonary embolism patients. Now, you have stabilized the patient. What next? Now, in the first thing, you started the patient on anticoagulation, right? So, how long are we going to continue the anticoagulants? Now, this is going to depend on what kind of risk factor for pulmonary embolism that the patient has. So, the patient could have a reversible risk factor, which could be again major reversible risk factor or a minor reversible risk factor, or the patient could have persistent risk factors. Or there could be a scenario where there are no identifiable risk factors for pulmonary embolism. Now, what kind of risk factors are we talking about? These. Now, I'm not reading the entire thing. Just note the major reversible risk factors include surgery with a general anesthesia lasting longer than 30 minutes, or a hospitalization with while confined to hospital bed for more than 72 hours, and so on. And minor includes the surgery with general anesthesia less than 30 minutes, or a hospitalization less than 72 hours, and so on. And persistent risk factors include persistent diseases like active cancer, autoimmune diseases, and so on, right? So, based on these, there is going to be a difference in the duration of anticoagulation. Now, if the patient has a major reversible risk factor, we are going to continue the anticoagulation for 3 to 6 months on maintenance doses. Now note here, the anticoagulation therapy is given in 3 phases. The first is the initiation phase that we gave in acute care. In the post-acute care, we are giving the initial therapy or the initial maintenance doses in patients with a major reversible risk factor. There's something called an extended therapy, and I'm coming to it in a bit. For the rest, minor reversible risk factor, a persistent risk factor, or if there are no identifiable risk factors, we are going to extend the anticoagulation beyond 3 to 6 months. This is the extended therapy that I was talking about. Now, why? So, see, in minor reversible risk factor, what happened? Despite the fact that there was only a minor risk, the patient still developed a pulmonary embolism. Or the patient has a persistent risk factor. The risk factor is persisting throughout. Or there was no identifiable risk factor, still the patient developed a pulmonary embolism. So these patients are prone to developing pulmonary embolism recurrently over and over again, right? That's why we are going to extend anticoagulation beyond 3 to 6 months. And what are we going to give? We are going to give DOACs. So DOACs are the preferred choice. We are going to give half dose of apixaban or rivaroxaban. This is the preferred thing over VKs. Now, what is the half dose? Half is half of the maintenance doses, right? Now, if the patient has cancer, both DOACs and low molecular weight heparin can be given, and these are preferred over VKs. If the patient does not have cancer and DOACs are contraindicated, then VKs are preferred over aspirin. And if anticoagulants are contraindicated in the patient or the patient refuses to take them, then low dose aspirin can be used, which is preferred over giving nothing, right? Now, suppose while on anticoagulation, my patient developed a pulmonary embolism again, a recurrent pulmonary embolism. What do? First of all, we increase the DOAC doses to a full dose, right? And if the patient was already on a full dose therapeutic dose of DOAC or an anticoagulant, we change the anticoagulant class. And if the patient has cancer plus a recurrent pulmonary embolism, we increase the dose of LMWH by 20 to 25%, right? Also, if my patient had no identifiable risk factor, we are going to do a detailed history and physical exam. And if the history and exam are suggestive, we are going to do age appropriate cancer screening. If the history is not suggestive, we are not going to perform unnecessary screening, but if they are suggestive, we are going to do it, right? Also, if there was a family history of thrombosis, or if the patient's age was less than 55 years, then we are going to test for genetic and acquired thrombophilia, right? So let's talk about the rest of the post-acute management. Now, I've already mentioned the duration of anticoagulants. Let's discuss the rest. The first is, after my patient is stabilized, we are going to target an early ambulation, meaning we are going to try to get our patient back on feet as early as possible as opposed to a prolonged bed rest, right? We are also going to plan a visit within 1 week of discharge to check for symptoms, adherence to therapy, and bleeding complications. Now, suppose my patient has uterine bleeding. For these patients, we are going to try hormonal therapy first. We might even change anticoagulants, but we are not going to stop anticoagulants completely. Now, after an episode of acute pulmonary embolism, for the categories C2 to E, a long haul travel was restricted for 4 weeks. At week 4, this restriction is lifted. Now, what's a long haul travel? It's a travel lasting more than 5 hours. And obviously, at week 4, the patient is still on anticoagulation. So, these patients are advised to wear compression stockings while a long haul travel. Now, suppose my patient already had a pulmonary embolism in the past and the anticoagulation therapy is over, and now my patient wants to do a long haul travel. For these patients, we might try giving a one-time prophylactic dose of a DOAC or LMWH on the day of the travel. We are also going to continue visits at or before 3 months after discharge to check for persistent pulmonary embolism related symptoms lasting for more than 3 months, and we are going to continue follow-ups till 1 year to check for again the same PH related symptoms and functional limitations. Now, where are we following up our patients? For complex patients, we are going to follow them up at specialized PE clinic. Now, who are complex patients? These are the patients with a complicated clinical presentation or a history of venous thromboembolism or recurrent PE, unresolved symptoms, a pregnancy-related PE, or a complex anticoagulant management, meaning there is a requirement of frequent anticoagulant adjustment. This could be a dose adjustment or a change in anticoagulant class due to a labile INR, that is a labile PT INR, or a fluctuating renal function, or due to anticoagulation failure or allergy to an anticoagulant, or a high risk of bleeding or an active bleeding. So these patients are going to be followed up at a specialized PE clinic. Now suppose we find out that our patient do have a persistent PE related symptoms. What to do? So at 3 to 6 months, we are going to do some exercise testing like 6-minute walk test or incremental shuttle test and so on. Apart from that, we are going to screen for CTEPD. For CTEPD, CTEPD is one of the sequelae of acute pulmonary embolism. We are going to discuss the syndromes, the post-PE syndromes in a different slide. For now, I am going to tell you how we are going to screen for CTEPD in our pulmonary embolism patients. CTEPD stands for chronic thromboembolic pulmonary disease. Now we can either go for a CPET first or a transthoracic echo plus a VQ scan first. I'm going to discuss this part first. This guideline emphasizes doing both a transthoracic echo as well as a VQ scan, not just an echo, right? And if the VQ scan shows a normal lung perfusion, we can exclude a CTEPD. We do not need the transthoracic echo. If, however, the VQ scan shows an abnormal lung perfusion, then the transthoracic echo becomes important. Now, the echo could be a high probability echo or a low probability echo. Now, what's a high probability echo? This means that the echo shows a TRV or a tricuspid regurgitation velocity more than 2.8 meters per second, and the echo shows signs of pulmonary hypertension. This is a high probability echo. So, if the patient has an abnormal lung perfusion plus a high probability echo, then CTEPD is likely, and these patients could have an additional pulmonary hypertension, and they have to be sent for expert evaluation where they might undergo pulmonary angiography, right heart catheterization, exercise testing and so on. Now, if I have an abnormal lung perfusion on VQ scan but a low probability echo, then CTEPD is still possible. And if I have CPET available, CPET is cardiopulmonary exercise testing. If I have CPET available, we are going to check for PVD limitation. What is PVD limitation? It means that the patient is showing exercise limitation due to a pulmonary vascular disease. So if that is present, then CTEPD is again likely, so we are going to send them for expert evaluation. If it's not present, then we can exclude CTEPD despite the fact that the VQ scan showed an abnormal lung perfusion, right? And if I do not have availability of CPET, then again, even with a low probability echo, we might send them for an expert evaluation where they are going to undergo further testings. Let's come to this side. What if we have CPET available right away? So, with the symptomatic patients, we can directly go for a CPET. And we check further again, we check for PVD limitation. If PVD limitation is not present, again we can exclude CTEPD right away. And if it's present, then we go for again the transthoracic echo and VQ scan, and we follow this algorithm, right? Now, lastly, coming to the clinical syndromes in post-acute pulmonary embolism patients. Now, after acute pulmonary embolism, some patients can remain chronically symptomatic, right? And some patients might develop residual pulmonary vascular obstruction. So, you have given your anticoagulation, you have done thrombolysis, but there is a residual pulmonary vascular obstruction. Now, all symptomatic patients will not have RPVO, and all RPVO patients are not going to be symptomatic. Amongst the patients who are symptomatic and do have RPVO, there is going to be a subset of patients who will have CTEPD, a chronic thromboembolic pulmonary disease. And the CTEPD patients who do have an additional pulmonary hypertension are regarded as CTEPH, chronic thromboembolic pulmonary hypertension. Now note, there could be patients who are symptomatic and have RPVO, but these patients may not have CTEPD. So this is in short the clinical syndromes post-acute PE. Now this is all from my side from the new guidelines and the recommendations on pulmonary embolism management in adults.